got a 62-year-old man come to you with worsening shortness of breath for the last 3 days. The patient has developed rhinorrhea and cough and thinks he might have contracted something from his grandchildren. He has 40-pack year history of smoking with baseline shortness of breath with exertion. He also has bilateral ankle swelling, mild overweight, mild respiratory distress. Lung auscultation revealed bilateral wheeze and prolonged expiratory phase. Well, if you look into investigation, WBC count is increased, hemoglobin count is increased. This is nearly normal. If you go for ABG, this is reduced and this is increased. Well, this indicates patient has type 2 respiratory failure. But absence of marked acidosis in this patient is best explained by which the following. Point to note that the pH is 7.34, which is normal. But still, there is no acidosis, because in acidosis, the pH should be very, very low. But it's fairly in the normal range. What's the reason for that? Well, the answer is renal tubular compensation is the answer. This patient has COPD, long history of smoking, and now type 2 failure is there. Extensive smoking history, 40-pack year history of baseline shortness of breath with exertion goes toward COPD, and that is confirmed by ABG also. And moreover, shortness of the wheezing and a prolonged expiratory phase, shortness of breath for the past 3 days, bilateral wheeze and prolonged expiratory phase, which is a feature of obstructive airway disease. There is a possibility of cor pulmonale also, additional. Why? Bilateral ankle edema is there, swelling is there. Well, I have a question for you. Stop the video, write down the answer. What is cor pulmonale? Quickly, stop the video. Well, the answer is, and believe me, this is done wrong by 99% people commit mistake on this question. Okay, the right answer is, it's a right heart enlargement. With or without failure. That means right heart failure may or may not be there. This is secondary to lung parenchyma, pleura, or chest wall disease. Okay, so it is the right heart enlargement, but people go for failure. It may or may not be, but although it is usually there, but it's not the exact definition, but usually there. But if you go by absolute definition, this is what I've told you. Now, the patient has presented to us with worsening dyspnea, significant hypercapnia. 65 is the CO2. We are all well aware normal CO2 is 40 to 45. This in the artery is the vein. And if you go for arterial blood gas analysis, so 40 millimeter mercury, and now it has gone to 65. Severe hypercapnia is there. Now, if you talk about chronic hypoventilation, the cause are COPD, the most common cause. Obesity, hypoventilation syndrome, okay, is other cause. Neuromuscular causes, various diseases, but they are very uncommon causes. And they usually have a gradual increase in PaCO2. It's not usually sudden increase. So this result in chronic respiratory acidosis, especially will go for COPD, which is the most common cause of chronic cause of hypoventilation. So now acidosis is going on, and due to increased CO2, and body want to maintain the pH to normal, the body will go for compensation. So to compensate, kidney increase bicarbonate retention. Well, we are well aware CO2 is a acid, bicarb is alkali. The body will try to retain bicarbonate so that pH is brought to normal. So that lead to a type of secondary metabolic alkalosis. So now when acute exacerbation of COPD, the CO2 can increase further, as we have seen in this patient also. So now comes the very, very important point. Normally the expected pH resulting from purely acute increase in CO2 from 40 millimeter mercury. Remember, I told you, normal CO2 is 40 millimeter mercury in artery. We always take arterial blood gas analysis. 45 is in the vein. We never take venous sample. So 45 to 65, it has increased. Okay. Well, and pH decreases 0.08 for every 10 millimeter mercury of acute exacerbation. How much exacerbation here? It is 65 minus 40. This is 25. This 25 millimeter mercury is there. So if you go by this simple calculation, that means 0.08, and somewhere around 0.4, it comes out to be okay. The pH should be 7.34 less than 0.20, somewhere around 7.14. pH should be there. Roughly what I done is 7.20, should be there, right? So simple calculation, somewhere around in the range of 7.12, 7.20. So this patient has near normal pH of 7.34. This is a large component of chronic hypercapnia for which kidney have enough time for compensation, because in the case of chronic, body already has done a lot of compensation by retaining bicarbonate. So in contrast to respiratory compensation occurring within minutes, metabolic component compensation, it takes nearly 48 hours. Okay. It's only evident in chronic setting. Point to be noted. I like to highlight more on, suppose there is a case of metabolic acidosis. Like in diabetes ketoacidosis. Now in this case, lungs compensate. What the lung do? They have a hyperventilation. And what is this known as Kussmaul breathing? Kussmaul breathing, lungs will try to wash out CO2. And that will try to remove acid and will try to bring back the pH to normal. This is happening in the setting of metabolic by the lungs by Kussmaul breathing. It's immediate, quick, but this quickness is not there. When the lungs have problem, the kidney take about 48 hours to compensate. But well, in our case, in a chronic case, chronic compensation has been done, and that's why pH is still normal. Compensation mechanisms normally do not normalize or overcorrect. That means it's never completely corrected. Okay? And it's never overcompensated usually. This point should be clear to you. So now let's look into other option. Electrolyte, erythrocyte chloride shift. In this, bicarbonate goes out and chloride goes in. It's a integral part of the CO2 transport. Normally happens. This is the initial response to respiratory acidosis but has a minimal effect on pH as compared to tubular compensation. Let me tell you what is the chloride shift, which is a normal phenomenon. Well, CO2 comes in, it combined with water to make H2CO3, and the enzyme involved is carbonic anhydrase. And this breaks down to H and bicarbonate. This bicarbonate goes out, is a negative particle to compensate. Chloride comes in, and this H will combine with hemoglobin to make HHB. So this bicarb goes out, chloride comes. This is normal. Okay, so chloride shift is not a very adequate mechanism to control pH. But now I have one more question for you. Which ion shift in RBC occurs in metabolic acidosis? Stop the video, write down the answer. The answer is potassium. This is the RBC. This is the blood vessel. Lot of acidosis, H ions are there. And we are well aware, potassium is an intracellular ion. This H ion will enter the cell, but as a positive particle has entered the RBC, as the law of electrostat, the potassium goes out. This is a basic mechanism why in metabolic acidosis, there is hyperkalemia is there. Okay, it's a compensatory mechanism. Now I have a question for you. Stop the video, write down the answer. I just told you that normally these two are together. But tell me, but there's some exception where patient can have metabolic acidosis with hypokalemia. Very, very important question. Stop the video, write down the answer. Tell me the metabolic acidosis with hypokalemia. Well, the answer is diarrhea. Severe diarrhea. Number 2, renal tubular acidosis, type 1 and type 2. The 3 conditions where we can have metabolic acidosis with hypokalemia: diarrhea and renal tubular acidosis. Well, increased dead space ventilation is the wrong answer. Is the main cause of hypercapnia and COPD and act to worsen the respiratory acidosis. Increased minute volume. The minute volume is tidal volume plus respiratory rate, and we know very well tidal volume is the amount of air which goes in and comes out in a normal breathing. In a normal breathing, like you and me are breathing normally, and whatever air is going in and out per breath is tidal volume. It increase minute volume to decrease CO2 and compensate for metabolic acidosis, small breathing what I talked to you. But due to underlying COPD, this patient is unable to significantly increase minute volume, not able to do it. In fact, that's why COPD is a case of hypoventilation, not hyperventilation. So COPD is a case of hypoventilation. What about pulmonary vasoconstriction? It results from alveolar hypoxia, and it can normalize shunting and ventilation perfusion mismatching within the lung, but does not compensate for respiratory acidosis. And one more thing, especially in a case of COPD, this is one thing which contribute to pulmonary arterial hypertension, PAH. This is a very important contributory factor, especially in case of chronic bronchitis. Golden line to remember: body compensate for chronic hypercapnia by increasing renal bicarbonate retention, creating a compensative metabolic alkalosis. Thank you very much.